gonna spend little time closing things that will bing or bong.
I know. So I know people are signing in right now. Good morning or good afternoon, everyone. This is Lisa Dulski-Watkins with the Milbank Memorial Fund, and welcome to our Multipayer Primary Care Network virtual seminar for October of 2020. We're just getting set up here, but lots of people are dialing in, and we will get started hopefully around 12 p.m. Eastern Time. Thanks for joining us. I would like everyone to know that the fuel truck happened to arrive just this very moment. So I'm going to go on mute for a second. Welcome, everyone. This is Lisa Dulski-Watkins with the Milbank Memorial Fund. We are about to get started with our October 2020 virtual seminar. We are very excited about our presentations and the subsequent discussion that's going to be occurring in the next couple of hours. I want to thank all of you for joining us today for whatever portion of the event you can be with us. Just a quick reminder, when you are logged in and using audio, if you have ambient noise like I do right now because of the fuel truck that is just backed up in my driveway, please remember to put yourself on mute, whether you're on the phone or using your computer audio to minimize ambient noise. And if you have dialed in using a phone number, I'd love to ask you to please identify yourself. There's a way you can either just tell us through chat what phone number is associated with your name, and we'll put you in as yourself. So we'll be getting started in just a few minutes. Just give people 1 or 2 minutes to continue to dial in. About 20 people on so far. We expect another 10 or so. So welcome, and looking forward to the discussion. Okay, I think we can get started, and I'm very excited about this meeting. This is Lisa Dulski-Watkins with the Milbank Memorial Fund. Welcome to our second in a series of virtual seminars that we're holding in 2020. I am delighted to be able to introduce our speakers for today once we get underway. But the first thing I wanted to do was just really thank you for continuing to participate in this effort to sustain our long and fruitful connections in pursuit of primary care transformation in a multi-payer environment. I certainly am looking forward to returning to in-person meetings when the time is right. But I'm really grateful for your willingness to connect with us at Milbank and with each other virtually. So thank you for being here. What I'd like to do to begin the meeting is to just briefly walk through the agenda, and then I'd like everyone to turn on their camera if it's not already on, and I'm just going to walk through our participant list and ask people to introduce themselves very briefly, just so we can say hello to each other, if only through our screens. So just walking through the agenda, we're going to have a panel presentation. We're very excited to be talking about community engagement with healthcare, and we'll be really learning about a case study that was created for us by Community Catalyst, highlighting the Oregon story through the Oregon Health Authority. And so we'll have a series of discussions following that as well. There will be a 10-minute break where I would please ask you not to fully sign out. You can certainly mute yourself and turn off your video, but don't sign out because then you'll miss all the chat and you won't be able to see any of the questions from or discussion. After that, we will be having a presentation from Dr. Sarah Scholey, who is at the National Committee for Quality Assurance and a nationally and internationally known expert in evaluation of patient experience through claims as well as through surveys, and we're very excited to have her wisdom shared with us. We will then be moving into some breakout sessions for informal discussions of this particular set of topics, and then adjourning at 3:00 p.m. Eastern Time. So once again, thank you everybody for being here, and turn on your screens, and I will start to ask people to introduce themselves. Sonika Kumara, our wonderful intern, just introduce yourself briefly, please.
Hello everyone, yeah, so I'm a student at Columbia's Mailman School of Public Health. I'm a second year MPH student studying health policy, and I'm working with Lisa and others at Milbank as intern.
Great, thanks Sonika. Chris Kohler.
Hi, it's Chris Kohler, president of the fund. Welcome everybody, great to see you.
Deb Hurwitz.
Hi everybody, this is Deb Hurwitz. I'm the executive director for the Care Transformation Collaborative in Rhode Island.
Thanks, Deb. David Sharp.
Hi, good afternoon. David Sharp with the Maryland Healthcare Commission.
Thank you. Julie Shills.
Hi, everyone. Julie Shills with Mathematica.
Thanks, Julie. Rachel Huber.
Hi, good morning or good afternoon. I am with TenCare.
Welcome, Rachel. Sheila Newquist.
I am Sheila Newquist. I'm with Blue Cross Blue Shield of Rhode Island.
Great. I have Caitlin. I want to make sure I have the last name for Caitlin. I'm sorry, I don't have that on your sign-in. No? Okay. Alicia Berkemeyer.
Hi, good morning. Alicia Berkemeyer with Arkansas Blue Cross and Blue Shield. Glad to be on the call today.
Welcome. Diana Bianco.
Hey folks, it's Diana Bianco with Artemis Consulting, and I am one of the co-conveners of the Oregon Payer Group.
Great. Barbara Brady.
Hi, I'm Barbara Brady, and I work for Blue Cross Blue Shield of Michigan.
Great. Cindy Moe.
Moe with Blue Cross Blue Shield of Montana.
Welcome. Della Gregg.
Good morning, or I guess afternoon for some of you. I am with the Oklahoma Healthcare Authority, which is our Medicaid program.
Welcome. Disa Osterhout.
Hi, I'm Disa Osterhout with Blue Cross Blue Shield of Montana.
Thank you. Bill Golden.
I am unmuted. Bill Golden, Arkansas Medicaid and Arkansas Office of Health Information Technology.
Great. Jeremiah Benoit.
Hi, good afternoon. I'm here with Blue Shield of Northeast New York.
Great, thank you. Christy Bowling-Demetz.
Hi, everyone. Christy Bowling-Demetz, CEO at Health Teamworks.
Welcome. Lance Butler.
I'm Lance Butler with My Health Access Network. We are the data aggregator in Oklahoma, as well as the payer convener and HIE for Oklahoma.
Welcome. Jonathan Leguesse.
Hi, everyone. Jonathan Leguesse with the National Payer Committee and Deloitte team.
Luann Villani.
Hi, this is Luann Villani from Adirondack Health Institute in upstate New York.
Welcome. Peter Bacchini. Maybe Peter stepped away.
Trouble with the unmute. Peter
Okay.
Bacchini from Aetna National Medicare Team. Thanks.
Yeah, welcome. Richard Schonk.
Hi, Richard Schonk. I'm the Chief Medical Officer with the Health Collaborative in Cincinnati, and we do data aggregation, claims data aggregation for the state of Ohio, as well as lead the CPC Plus learning and diffusion work.
Great, thank you, Dick. Susan Stewart.
Hi, everyone. Susan Stewart. I'm the payer convener for the Capital North Hudson region of New York.
Great, thanks. Vince Steenberg.
Yeah, hello everyone. Vince Steenberg with MVP.
I think we may have muted everyone briefly here. Vince, I think you got cut off. I'm sorry. Do you mind just reintroducing yourself?
Yeah, sorry, got some rough connection. A storm came through here yesterday and without power. So Vince Steenberg, MVP Healthcare Network Program Manager for CPC Plus, North Hudson Capital Region, New York. Happy to be here. Thank you.
Thank you for joining us. Yi Mao.
Hi, this is Yi Mao with Michigan Multipayer Initiative.
Welcome, E. Diane Beecham-Marriott.
Hello, Lisa. This is Diane from Michigan. So grateful to be here.
So glad you're here. Summer Boslaw.
Hi, this is Summer Boslow with the Oregon Health Authority.
Great. Eric Muther.
Hi, Eric Muther from the Greater Philadelphia region. Happy to be joining as long as Comcast continues to allow.
Thank you. C. Karianopoulos. Okay.
I'm
And
sorry.
That's okay. Okay.
I didn't realize I was muted. I'm attending with David Sharp. He may have to jump off to attend a brief meeting. So I've been supporting him for 12 years and I look forward to the meeting. Thank you.
Great. And then I'm going to welcome our speakers separately as we move forward. So once again, welcome everybody. Thank you for saying hello in person. Feel free to now mute yourselves and make your video go away. And we're looking forward to having a wonderful discussion. Sanika, do you mind moving on to the slides? Thank you. So I would like to introduce our panels as well as just talk a little bit about what we're going to be discussing today. And as some background, I think there's wide recognition that patients and caregivers must play a central role in both assessing and shaping the delivered healthcare services that they receive. This has proven hard to achieve in many circumstances, but the following presentation that we will be enjoying will describe a long-term and successful example in Oregon. So to start, I want to just give a very brief, the bios for all of our speakers are on the agenda, but just briefly, I want to introduce our speakers. Chris Demars is the director of the Oregon Health Authority Transformation Center and the Deputy Director of Delivery Systems Innovation Office. She plays a lead role in a huge number of the various collaborative efforts underway in Oregon, and we're delighted to have her take the time, which is very dear, to be with us today. Working with Chris is Tom Cogswell, who's the project coordinator and event planner at the Oregon Health Authority Transformation Center. He's been there since 2013. He's here to give us some additional information in addition to what Chris will be sharing with us about the programs that you're going to be hearing. And then, of course, we have Renee Marcus Hoden, who is the author of the case study that we will be hearing about in very good detail. Renee is the Deputy Director of the Center for Consumer Engagement and Health Innovation at Community Catalyst. And she has years of experience in the legal side as well as advocacy side for the patient voice, and we're very excited to have her with us. So with that, I'm going to turn it over to our speakers. Please feel free to use the chat function to make sure that your questions as they occur to you get logged, and we will make sure they get answered towards the end. I think we're going to try to have the presentation move through without interruption, but if there's something you really must ask your hand or share, feel free to raise your hand using electronically or the chat function, and we'll make sure that we get that done. So with that, I'll hand it over to you, our speakers.
Great, thank you. So we thought we would share first, a little bit about us, a little bit more, not about ourselves, but of the organizations we represent. So Chris, why don't you start, and then I'll talk about Community Catalyst.
Sure, thank you. Thanks, Lisa. Thanks, Renee. So nice to be here, everyone. So I'm as Lisa said, the director of the Transformation Center, and the Transformation Center's goal is to support innovation and quality improvement across Oregon's health system reform efforts. And supporting community advisory councils has been a huge part of our work since we were created in 2012. We engaged Community Catalyst as a consultant to help with some of our community advisory council supports over the years. So it's real pleasure to work with Renee and her team on this case study.
Great, it's been my pleasure as well to work with you. And again, thank you, Lisa and Milbank, for having us today. Just very briefly, for those of you who don't know us, Community Catalyst is a national nonprofit consumer healthcare advocacy organization. We really work to bring the voice of historically excluded or underserved populations to debates around healthcare. And the Center for Consumer Engagement and Health Innovation is kind of the side of the house where our work on delivery system reform lives. And so we work at state level, working with advocates, local and state level. We do research and we work on policy, and we also provide consulting services to healthcare organizations looking to improve their engagement. Why don't we go to the next slide? We thought we would ask you all to help us with a poll, just so we understand a little bit about your level of engagement so far. So we have a poll. In what ways has your organization engaged consumers? And that could be, of course, since we're in various places, members or patients or clients in organizational level decisions. It's really not talking about engaging them in their own clinical care, but rather at organizational level decisions. And so we have a couple of choices. Somebody can put up the poll. I'm not
Sorry,
seeing it.
Nope, it's not up yet.
Okay, great.
Cindy, I'm gonna reclaim the host for a moment so I can put the poll up. Okay.
Great, now I can see it. So again, we've had a number of different areas. If you have, people on your governing board, an advisory council of some sort, quality improvement activities, out in the community holding kind of town hall style meetings, focus groups, surveys, and there may be other things as well. And you should be able to vote for as many as you use. So we'll just take a minute to have everybody select their choices. Okay. All right. Whoever is in charge of the poll, you want to show us the results?
So far, I have no one having voted.
Oh, Are people having trouble seeing it?
No.
I voted.
No, I voted as well.
All right, ready? I'm gonna see what happens here.
Oh, there we go. Okay, so lots of folks use surveys, little close to 45%, advisory councils and focus groups, about the same. Some, about a third, consumers on the board, that's great. And a bunch of other folks use town hall style meetings or QI. Great. Okay, well, why don't we, that's really helpful as a starting place, because I think, you'll see, some of this reflected in the presentation today about what's going on in Oregon, but also it's just helpful to have a sense of, how familiar folks are with these strategies. Okay, why don't we, move forward. And I thought what I would do is provide a little bit of background. As many of you probably know, and some of you better than others, the CCO initiative, or the Coordinated Care Organization Initiative, was established by the Oregon legislature back in 2012, and it created these local networks of healthcare providers that receive a global budget to serve Medicaid or Oregon Health Plan enrollees. But while you may be familiar with that, what you may be less familiar with is that the legislature also included in that law a requirement that each CCO had to create at least one community advisory council. They call them CACs in Oregon, and you will hear more about them. And as we saw from the poll and from probably folks, other knowledge from the literature, advisory bodies aren't uncommon these days. But I think, we all know that the bodies can all too often be kind of a check the box requirement. But through my work, consulting with OHA, as Chris mentioned earlier, it occurred to me that something very different and special was happening with their CACs, and that was that the state was really investing a lot of time and resources into making these bodies work, and so breathing real life into the requirements. So we approached OHA and eventually Milbank, and we proposed to kind of look under the hood, if you will, and figure out what it really takes to make these bodies meaningful. Next slide, please. Okay, so just to share very briefly, oh, wait, one back for, yeah, there we go. Just very briefly, what we did in order to do this case study. So aside from reviewing documents, we did a lot of interviews, both with OHA staff, so Transformation Center staff and leadership. We talked to innovator agents, which you'll hear a little bit more about from Chris in a bit. And then collectively with the transformation staff and the innovator agents, we chose 3 CCOs to look at. And we chose them based on a whole bunch of factors, including diversity of geography and diversity of approach to their CACs. Then under those, we spoke to the coordinator, a CCO designated coordinator of the advisory committee, or council rather. We spoke to members of OHP, the Oregon Health Plan, who were members of the CAC, and we spoke to the specific innovator agents connected with those CCOs. And I also had the great opportunity to attend a CAC meeting while I was out there late last year. So that's a little background about why we did what we did and how we did what we did. And I'm actually going to turn it over to Chris to flesh out, a little bit more about the program.
Thanks, Renee. Next slide, please. So community advisory councils are in legislation. They're a statute. They were created, the statute went into place in 2011, 2012. And what you see on this slide are some of the requirements of community advisory councils. They have to be, as Renee kind of alluded to, made up of at least 51% Oregon Health Plan or Medicaid members. They also need to have a representative from each of the county governments within the CCO, and that can vary dramatically from 12 counties in Eastern Oregon to significantly fewer number in other of the community advisory councils in the CCO regions. And they also should represent kind of perspectives of the major health issues that are identified in another legislative requirement of the CACs, which is a community health assessment and developing a community health improvement plan to kind of guide the direction for the CCO around preventive care practices and wellness for the CCO's activities. And I want to point out that the community health assessment, community health improvement plan are not just for the CCO's members, but they're for the entire geographic area, which also is unique. The CAC has this perspective that's community-wide, which is really important, I think. Next slide, please. So this slide shows some of the ways the community advisory councils are supported. So you see on the left-hand side, the Transformation Center, and we have had a learning collaborative for the CACs since the beginning, since 2012. We have a designated staff member, Tom Cogswell, who you'll be hearing from, as well as a few other of us in the Transformation Center that provide assistance as well. We provide technical assistance to CCOs and specifically to the community advisory councils. Also, you heard Renee mention the innovator agents. These are also staff at the Oregon Health Authority that serve as a conduit between OHA and the CCOs and play a whole host of roles. But one of their roles, and this is also in statute and legislation, is that they attend all the community advisory council meetings and provide support to them. So that's another kind of key support that's coming from OHA. And then there are the CAC coordinators, and as Renee mentioned, these are staff, generally staff within the CCOs that kind of play a management or coordination role, as the title indicates. And then finally, there are the CAC members, and I mentioned kind of what the requirements are for those, that membership. Next slide. So this gives a little more information about the types of support that we provide to the community advisory councils from the Transformation Center. We host an annual, generally it's been an in-person conference, obviously not this year, but we will see, and hopefully we'll be able to resume in person soon. And those are very well attended, and the community advisory council members say that it's so valuable to be in a room and in a space to learn from other CACs as to how they're doing their work, because many of these CAC members and the Oregon Health Plan members in particular may not have participated in a kind of organized advisory body such as this. We also host peer-to-peer networking calls on a regular basis. Generally, it's been monthly. Since COVID, they've even happened at times more frequently because there's been so much of a need to kind of learn from each other and how they're supporting their CCO's work and their members during COVID. We've hosted additional in-person trainings, and then we've a whole host of webinars, recruitment materials. Recruitment and engagement and retention has been an area that we identified through surveys of the CACs where there's been a lot of need, so we've really focused on that. And then there are the innovator agents that I mentioned earlier. So next slides, please. So with that, I'm going to pass it on to Tom Cogswell, who's going to show you some of the resources that we have on the Transformation Center website for the community advisory councils.
Thanks, Chris. And I think if whoever is sharing their screen can just enable me to share. Thank you. Okay, just give me a thumbs up if you can see my screen. Great, thank you. So I just thought it'd be helpful to just spend a minute and orient everyone to the kind of resources that Chris was just talking about. So this is our CAC supports page, and this is on the Transformation Center's website. So you can just go to transformationcenter.org, and that will redirect you, and you'll find CAC supports here. We have developed quite a bit of resources on everything related to the work of the CAC. Chris was just talking about, you know, identifying CAC member recruitment as an ongoing challenge. So we've established these resource guides, and I'll just click on this one to show you what this looks like. So this is really a compilation of resources and tools, either that we in the Transformation Center have put together, or strategies that maybe we've pulled from other organizations such as Community Catalysts. It also includes some outreach and recruitment templates, and then links to webinars that we've hosted. So one of the key resource documents that folks said they've found helpful so far is the CAC Handbook of Best Practices. And so, you know, this is really, in our role, just lifting up best practices that are successful for CACs and just documenting them. It's pretty simple. So we have this broken down in different areas of the CAC, everything from setting up meeting and putting together agenda templates and charters to recruiting members. Just click on this real quick. You can see here. So what we try to do is basically list out some best practices that we've identified, provide a little bit more information and details about what that looks like, and then link to some actual examples from CCOs or CACs. So Health Share of Oregon is the CCO that represents Portland, Oregon, Tri-County, or one of them now. So that just to give people that are maybe needing a new or fresh you know, set of strategies, if they're having trouble with recruitment, if they're having trouble engaging CAC members in their meetings, that they can go back to this document and try out some new strategies. So the other thing that Chris mentioned is that we host a couple peer-to-peer meetings, and those are linked here. We have a meeting for the CAC coordinators, who are basically the CCO staff people who are responsible for coordinating the work of the CAC. We have another meeting that's open to the coordinators and actual CAC members, and we've been using that as a peer-to-peer network, but also to help inform OHA about the work that's going on with CCO 2.0 implementation. And Chris will touch on CCO 2.0 and impacts in terms of CACs a little bit later. But really to hear more from the CAC members across the state to get their perspective about how best we can support them. One of the new requirements with this new phase of CCO contracts is that CCOs must appoint 2 CAC members to serve on their governing boards, which is really exciting. So we're actually starting this month a new learning collaborative or peer-to-peer network specifically for these CAC members, some of which who have had experience on their board of directors already, because maybe their CCO, you know, had already appointed them before CCO 2.0, and some who are just starting. So that's something that we're very excited about, and hopefully we'll be able to have more learnings and lessons learned to share pretty soon. Then the rest of the site is really just devoted towards, again, upcoming learning sessions and webinars. And Chris mentioned, yes, you know, pre-COVID, we did host an annual CAC conference and hope to get back to that soon. So we have materials here from the past 6 or 7 years of conferences. Okay, go ahead and stop sharing.
Thanks, Tom.
All right, and I just want to call out Tom's amazing work in this area. Obviously, there's a lot of resources, and he's been part of the helping to run the CAC Learning Collaborative since the beginning. All right, so successes and impacts that were identified through Community Catalyst and Renee's work. So the first is around health and wellness resources, and I won't spend too much time on this, but just to quickly highlight that the way the CCO model works is that CCOs can receive some quality incentive dollars for reaching some targets or benchmarks on a certain set of quality metrics. And in many cases, CCOs take that money that they get from their quality incentive pool dollars and they dedicate those to the community advisory councils to make decisions about how that money should be reinvested to address community health priorities as identified in the community health improvement plan. So this is a really exciting role for the CACs, and some programs that they've funded over time are fresh vegetable prescriptions, initiatives aimed at promoting adolescent well care visits, gym memberships that encourage wellness. There's been a life jacket station at a local lake, cleats for walking on snow and ice, and walking poles to promote exercise among older adults. Another success is the collaborative health planning that happens. So yes, the CACs are responsible for the CHA and the CHIP, as we call them, but because they have such a diverse representation, because of this role that they play often in making funding decisions, it's a place where kind of cross-sector representatives come together. Many CACs have a housing representative or someone that works for a food bank, and they kind of work together to help advise the CCO's investment. Another success is improving CCO's policies and procedures to make sure that the CCOs are really designing their work to most greatly impact members and make necessary adjustments. So for example, in one CCO, the CAC heard from members that receiving help for paying for gas would be really useful. And there's a complex process for reimbursement that they kind of advise the CCO and how they could do that. And I probably should have pointed out already that it's probably kind of clear that there is a great deal of flexibility within CCOs as to the type of services they can provide support for, and it's through a program called Health Related Services, and happy to answer more questions about that if you want, but that kind of allows for the CAC to have more of an impact and really advise on kind of the whole range of really social determinants of health, health-related social needs beyond medical care. And then also, health planning is more inclusive for the CCOs with CACs involved. And there are some strategies that CACs have put in place to really increase inclusivity for those that may not have been able to be involved in planning process. Like for example, one of the CCOs, one of the CACs has created a plain language summary of key highlights in the Community Health Improvement Plan. Many of you have seen community health assessments. Many of you have seen these kind of assessments. They can be really data heavy. This is really a plain language, kind of accessible for all members of the community, and they also translated that into Spanish. Next slide. There were challenges identified in the case study as well. We've already touched on recruiting and supporting OHP members and participating in the CACs. And really, like for example, funding supports for CAC member attendance. Some of them would have to travel, and meetings were in person, travel quite far, and being able to reimburse for travel or childcare is something that needs to happen and doesn't always happen in order to support kind of the diverse representation that we're hoping for on the CACs. Making sure that CACs represent the diversity of their communities. Translation and interpretation services often are not existent and remain a barrier. Sometimes the meeting times or location might hinder more diverse membership if meetings are, for example, during the day and people are working during the day, and they could participate if they were in evenings as well. And some of these issues and some of the best practices to address some of these challenges are identified in that best practice document that Tom referred you to. Another challenge is really measuring the impact of the CACs. There has not been to this date a robust evaluation of the impact of CACs, although we are currently in the process of developing that, and excited to kind of make that more of a kind of methodologically sound evaluation. We know from anecdotes that CACs are effective, but we would like to have it and more in a formal evaluation. And then also there are differences among regions that kind of hinder CACs from being able to realize some of the legislative requirements and some of the ideal kind of processes. So for example, in Eastern Oregon, I've already alluded to this, but it's the Eastern Oregon CCO, it's the entire eastern part of, and it's a quite large area, and the innovator agents and the CAC coordinator would want to participate in all the meetings. Well, they have 12 CACs and 1 CAC for each region because of the geographic diversity, and geography just serves as a barrier to making sure that those kind of supports, that the Transformation Center can get out there. Sometimes we try to visit some of the CACs, and it's really hard when there's that geographic barrier, just as an example. So next slide. So with that, I'm going to pass it back to Renee.
Thanks so much. I really appreciate, OHA sharing what they've been doing, but also, these were not just things that were identified throughout the case study or, in the process of developing the case study. But I think, OHA, because they're so in touch with, the transformation staff is so closely in touch with the folks that are working on the CACs, these were not surprises. These challenges were not surprises at all. So I wanted to sort of take just a step back and say that, when thinking about best practices, these are not best practices just for OHA. We really believe that the lessons that we're extracting here can apply across many different settings. Obviously, just from the introductions, I could tell you guys are, engaged in many different ways with consumers. And so we tried to pull out those things that we think have applicability. So first of all, it's very clear that prioritizing engagement is essential. After years of careful and thoughtful work that the OHA and the Transformation Center have put into empowering the CACs, they've made them relevant and visible, and it's paid off. And in fact, you'll hear a little bit more from Chris in a bit about when they were planning for the second phase of the CCOs, the stakeholders, they did a very large stakeholder engagement process, and stakeholders across the spectrum prioritized CACs and assigned them a more significant role in achieving the overall aims of the statewide CCO initiative. Prioritizing also means investing staff time and financial resources, and it's very clear from the list of activities and supports that Chris mentioned earlier, whether that's at the Transformation Center staff level, the innovator agents, or the consultants like myself, those all cost something. So devoting the time and the resources that it takes to make it real is critical. You can't kind of do it as a real side gig. The other best practice, which may seem sort of obvious, but it's not always, is about giving people meaningful work. People know when they're just sort of, window dressing. They know if they're being taken seriously and if they're seeing the outcomes of their work. And if they actually see those outcomes and impacts, they're going to keep coming back. And I will say, referencing something that Chris said earlier, the OHP members that I spoke with really liked being involved in that distribution of reinvestment funds. It was very tangible. They saw, they presented what was needed in their community because they're on the ground and see it. And they had a role in making something happen. So that was a very concrete way of seeing their experiences being taken seriously and seeing then the outcomes of that work. Speaking of outcomes, and Chris alluded to this before, but measuring and communicating outcomes is clearly an undeveloped area, as Chris said, in terms of measurement. It needs more attention, but in the meantime, keep tracking process measures. How many people are involved, how often are they getting together, what's the diversity of those participants. Those are all really important to know. And then as the work continues and there are impacts to point to, it's really important to let others know about that. So I think the advisors themselves, wherever again they sit, that will keep them coming back. That shows that you're valuing the work, and it also conveys to your audiences, whether it's all of the membership of a plan or the community out there that you serve in general, you're conveying your organization's values. So I would say it's not just about the measurement at whatever level, but also the communication of that. Another one is supporting an inclusive environment. And this takes a lot of thinking and effort. It's kind of all about the details. There's certainly obvious things around like translation, interpretation, making a room, when we were still meeting in person, making a room accessible for people with disabilities. But it's to make it an inclusive environment, it's really about creating a space where people's life experiences are seen as valuable, and acknowledging that everyone has something to teach, everyone has something to learn. And so it gets down into some of the minutia of like how people are seated, who speaks first, do we use people's first names or do we use their titles, for some and not for others. So thinking hard about inclusivity is a really important best practice. And then finally, and we see this in spades with the Transformation Center, sharing what works. We don't have to keep reinventing the wheel. And that best practices guide that Tom showed us earlier is a perfect example of how to capture those lessons and make sure that folks have easy access to them, templates that they can adapt, strategies that they can try in their own region. So that learning community approach, however you can build it, whether that's across plans, whether that's across states, it can't be, I can't say enough about how important that is. And so with that, let me just pass it another time back to Chris to talk kind of about the next chapter of CCOs and how OHA is kind of thinking about community engagement in light of what's been going on this year, both COVID and a renewed focus on racial justice.
Thanks, Renee. So this is the map of Oregon, and it shows the CCOs that are in place right now as of January. So we call this CCO 2.0. It's the second 5-year contract, essentially. And as part of that, as part of the process to get to this place, we went through practically, I think it was about a 2-year policy development process to kind of set new requirements for the CCOs in 4 areas that were identified by the governor. And some of those areas, just so in case you're interested, are maintaining a sustainable rate of cost growth, behavioral health, value-based payment, and social determinants of health and health equity, which are together. So next slide. So this slide shows some of the new requirements for CACs. We basically stood back and said, okay, how can we make the CACs even more effective and ensure that they truly represent the community voice and have an impact on the CCO's activities. And so This has been mentioned, I think, by Tom already, but there's a requirement that 2 CAC members sit on the CCO's governing board. It used to be just one, and that one of those members now needs to be a consumer representative. There's now a requirement that if a CAC is in a region, if a CCO is in a region with a tribe, that there be tribal representation on the CACs. CCOs have also need to carve out a role for the CACs in reviewing social determinants of health and health equity spending. I alluded before that in many CCOs, this was kind of already happening, but now it's a requirement that it happen across all CCOs. And then finally, the last bullet kind of alludes to there's now a requirement that there be diversity of the populations in the CCO's geographic area with a specific emphasis on people who are representative of populations that experience health disparities. And there is an annual demographic report that the CCO has to submit to show that that is the case. Next slide, please. So now I'm going to shift gears just a little bit because it just feels like if I weren't to talk about this, it would be wouldn't be representing kind of what's happening within Oregon and within kind of our time right now in the for all of us in the country. So CAC has been the model that we have stood up within the agency to kind of that we're really proud of, but it's not the only way, and it's not the only area where we need to focus on community engagement. And so I just want to give the 2 slides, kind of a short summary of where the agency is with regard to community engagement as well. And hopefully some of you will find this relevant to your work in your states. And so before COVID hit, the Oregon Health Authority leadership, we'd gone through a strategic planning process, and at the end of last year identified our 10-year goal of eliminating health inequities in Oregon. And then COVID hit, and it made that goal all the more important. And what I have there in italics is from a recent report that came out from OHA leadership, that we recognize the impact longstanding health inequities rooted in systemic racism and oppression are having on COVID-19 infections in Oregon. So next slide. So our 10-year goal, so we've kind of from our OHA director on down have doubled down on this 10-year goal and been even more intentional about the strategies that we need to put in place in order to achieve it. And we're just getting to that place right now. Obviously, COVID took everyone away from being able to focus on that for a few months. And now we're back. And we recognize that achieving this goal is going to involve community collaboration, shifting resources, priorities, power, changing practices. Which is going to require, and it's already starting I'm seeing this play out in real time, honest reflection, hard conversations, and tough decisions. And so some of the strategies that are being discussed, I mean, honestly, like this week, is how to diversify the committees that kind of influence and report to what we call the Oregon Health Policy Board, which is our health policy making body in the state. And advises the OHA and the governor on health policy, really making those committees being more representatives of communities that are experiencing health inequities, and then more intentionally building community input into the work that the Oregon Health Authority is doing. So all this is to say is we have the expectation and had an expectation for CCOs for a number of years now, and we need to, and we are practicing what we preach within our agency as well. So next slide, I'll pass it back to Renee.
Great, thanks so much, Chris. Really appreciate hearing what you all are doing currently. Given the tough environment we're in. So I believe we still have enough time, and Lisa can give me thumbs up or not. Thumbs up, okay, great. We were hoping to engage you guys and hear from you about your own experiences. Obviously from the poll, we know you have experience doing this work, and we'd love to hear from you what strategies that you've used in any of those engagement activities that you're kind of most proud of, or the other side of the coin, what your greatest challenge has been. And I guess what I might do is go against what I said earlier. I thought we would do the discussion question for all of you and then go to Q&A. I think we should just blend it. So if you have either an answer to one of these questions, sharing with us what strategies you've tried that you think work, or things that have been challenging, or a question for any of us, Chris, Tom, or myself. Let's just open up the lines and hear from folks.
Great, and so this is Lisa. I just wanted to add one more discussion point for consideration. So this is a largely payer-affiliated audience that's on the line with us today. And so obviously the case study didn't really explicitly address payment innovations like alternative payment models, et cetera. But the lessons here certainly can be relevant for payment redesign. So just that we have that lens available to us with this group is a great deal of thought and conversation going on within these organizations about these very issues. And so sharing that side of the experience, I think, will be helpful today too.
Great.
So I'm going to put forward a question that came from one of my colleagues in the chat, which specifically was around measurement, and if there are specific kinds of quality measures that the CACs are actually assessed or measured upon.
The answer is no. They are not. There are other requirements. I mean, I mentioned the contractual requirements for CACs, and they are going to be measured on that. For example, the diversity, kind of diverse representation in that demographic report. But I wouldn't necessarily call that a metric per se. Tom, do you have anything to add there?
Yeah, what comes to mind is in terms of tracking CAC's impact with social determinants of health and equity spending. I mean, we receive at OHA annual health-related services policies. Chris talked about health-related services are really a mechanism that CCOs can use to address social determinants of health. And so since CCOs are now required to carve out this role for CACs, we'll be looking at the extent to which CACs are involved in those decisions. So that's one example.
Thanks, Tom.
So then there's a follow-up question. I think I may actually call out my colleague who's asking these questions because she and her team in Michigan have been actively and successfully pursuing their patient advisory councils through the state, including, as you've done, in-person opportunities. So Diane, I'm just going to ask your question for you, but then I think you may want to follow up.
No, I'm grateful. This is Diane from Michigan, and our work has been specific to engaging consumers within our primary care demonstration projects, but your work is on a larger platform. And I was curious about whether your assessment substituted for or complemented similar assessments done by health systems in the state as they look at their planning needs as well. Just curious about how those two coexist.
Well, so the CAC is set to advise the CCO, which is kind of it's a payer, if you will. So the Oregon Health Plan, we have a contract with the CCOs, but then they have the relationship with their CACs. But that it's not necessarily at the provider level, and maybe that's what you're asking. I'm not sure.
I think that helps. So it's, to me, it would be a compliment too. Yes, thank you.
Yeah, it sounds like it's a compliment. Yeah, exactly.
So any responses to these questions? I mean, I think this is, as we talked about at the very beginning of the hour, there's the opportunity to make it real as and we had a commentator write a companion piece when we published this case study in August, who was concerned describing his experience trying to implement this type of advisory function in a densely populated urban environment in New York City. And the question really is how you get from square one to where you want to be. And so I guess I'd love to hear from those of you who have been working on this. I know that there has been a lot of effort. Looks like, and in Rhode Island, we had some comment from Deb Hurwitz, and I'll just read what she wrote, and Deb, you can follow up. In Rhode Island, we're piloting Pathways to Population Health, which is designed to strengthen clinical community linkages between primary care, their community health team specifically, and CBO and health equity zones. So a person with lived experience is part of the team, and the focus is at the community level. Deb, I don't know if you wanted to add to that further in terms of how you've been able to recruit successfully for those people serving in those positions, and if that's been a challenge in terms of keeping people engaged.
Well, we just concluded like a 5-month pilot. Can you hear me okay?
Yeah, we can.
Okay, good. We just concluded a 5-month pilot, and we were able to recruit, community health teams and, organizations in a particular community that were willing to participate. So this again was like sort of at the community level. And through the partners that came to the table, collectively they identified, a way to outreach to, individuals. In this particular case, it was called the Health Equity Challenge, and it was focused on diabetics that were in the community and at risk because of COVID-19. So using Pathways to Population Health model, we pulled a team together that had community health, the community health team, primary care, community-based organizations, and what we in our state we have what's called the HES, which is really infrastructure that's built in particular sort of zip codes that have health equity disparities. And so, pulling those teams together, those individuals were able to then outreach and identify a person, which we called with the lived experience. So in this case, it was, a person with diabetes that lives in that community to be part of the team. And then they went through a whole process of looking at what were some of the challenges for individuals. And then, also looking at the community level, how, what were the gaps, and then started to work on a plan to address that. And, in these cases, given the short period of time for the pilot, they focused on food, access to, fresh, healthy food for people with diabetes. So, that's how that worked. It was a very specific model. It's a team-based approach. It brings the consumer voice right to the table, and then starts to really build the relationships between key individuals in that community to address a health equity concern.
Deborah, thanks for that. I had, that sounds like an exciting initiative. You said it was a 5-month pilot right now, right? It's been a 5-month pilot?
Yeah, actually, we're going to be extending it now through June 30 of 2021. Mm-hmm. And as of July 1st in 2021, our Medicaid agency has put forward an investment strategy, they call it, social determinants of health. And there's several pillars to this, but it's sort of exciting. They're looking at making a $3.5 million investment in addressing and putting the infrastructure in place to address some of these social disparities that affect health. And so community health teams are sort of one of the key components. We kind of look at things as like upstream, downstream. So, downstream is our primary care docs giving individual care, kind of midstream is our community health teams and, community health organizations. And then way downstream is our HES that really looks at community solutions from a policy perspective or from a, infrastructure investment perspective at the community level. So, so what's kind of neat about this model is that, it will engage, the community health teams, the HES, and also it's going to introduce another element, which is participatory budgeting. And so the communities will have a say in, you know, a certain amount of funding that would be used to invest in something that's going to meet a need in the community. And so that's going to be sort of an interesting, you know, piece, you know, so that we're doing here. So, you know, we're really excited about, you know, the opportunity to sort of continue to take what I believe are a lot of good pieces, but really use a framework and a model to kind of link them together, really tighten it up, and you know, and continue to bring it to the level of the community and have that community voice and participation, active participation in the program.
That's great. That's exciting. The participatory budgeting is very exciting.
Yeah, it's interesting, isn't it?
I was in Scotland a couple of years ago talking a lot about participatory budgeting. There's a lot of good examples there. But anyway, I don't know if you guys have planned this, but you might want to do just a little, because we've been talking about measurement and all that. Might want to do a little qualitative evaluation of the, you know, of the pilot to see what the experience has been like for, you know, the individuals, you know, with diabetes who've served on these bodies, on these health teams, and the health teams themselves, to understand what the impact has been of having that person on. Since you're going to be continuing through at least the middle of 2021, you might, you know, see if there's any tweaks you need to do to that. But
yeah, absolutely. And you know, we you know, did a nice little debrief and got a lot of, you know, got a lot of feedback from the two teams, and they really valued the voice of the consumer at the table, and having that voice of the, you know, person with the lived experience. It was really well received and really helpful.
Mm-hmm.
And you know, we're working with Dr. Soma Shaha, who was formerly with IHI and is now the leader of the We in the World organization, that really is kind of working with us as, you know, subject matter expert and consultant to help, you know, implement the Pathways to Population Health model. And so there are some elements, some evaluation tools that we talked about, and I think we'll be using that in the next round.
That's great.
Yeah.
Thanks, Deb.
Yeah, thanks.
Any other questions or comments for our speakers? I know that the Oregon team had, they have a sort of hard stop at the top of the hour. So I think they may have already are heading off soon. Is that correct?
Yes.
Okay. So any last questions for Chris DeMars or Tom Bogswell?
So maybe if you just go to the last slide, one more. There we, nope. Forward.
Yeah. We'll get there.
The last slide. And I know these slides will be distributed, but we wanted to give you just some quick links. Oops, maybe we went to one, I'm not sure. But that last slide, there you go. The last slide gives you some links. First one is to the case study. Second one is to that page that Tom was, you know, tooling around before and showing you what's there, including that handbook of best practices he showed you. You can find it on that page. And then I also put in a link to a resource that Community Catalyst recently completed with the Healthcare Transformation Task Force. It's a change package. It's really kind of a step-by-step guide to from wherever you're starting at the beginning or somewhere in the middle, to engaging consumers, again, kind of across the spectrum of healthcare organizations. So to the extent that that's helpful to you, we encourage you to take a look around there too.
Great. Okay, well, I want to express my sincere thanks to all of our presenters today. I understand that everybody has a very full plate with other responsibilities, and we really do appreciate your willingness to share your experience and wisdom with us. So I'd like to continue this discussion, and thank you so much for for being part of this today. We are a little bit ahead of schedule, which is, as anyone who knows me, this is extremely unusual, but I think we'll just take advantage of it. We will start our 10-minute break a few minutes early. Please, everyone, come back before or at 1:30 when Sarah Scholey will be presenting about evaluation patient experience in 2020 with her tremendous experience at NCQA. And as a reminder, if you are stepping away from your computer, please don't completely disconnect because it will make it harder for you to come back in and get you in the breakout sessions later. So thanks, everybody. Enjoy your few minutes of break, and we look forward to seeing you in a little while, right at 1:30.
So Lisa, I would just say before everybody takes off, just if you want to follow up with me on any issue around consumer engagement, or of course, I imagine that Chris and Tom are open to hearing from folks to find out, if they need if people need more specifics about Oregon or some more lessons learned. I think we're probably all happy to follow up.
Thank you so much, Renee. We really appreciate your willingness to serve as an ongoing advisor in this journey that we're all on together. And once again, thank you for your really well-crafted work and presentation.
Great. Have a good day.
Okay, bye-bye.
Thank you for your interest. Bye.
Sarah, are you still on?
Yes, I was going to say, is this a good time for me to try?
This is an excellent time. So all you need to do is to go to that little green arrow should be at the bottom, like a bottom toolbar. It says share screen.
Yeah, I'm.
Great.
Let me just see how that works. I'm actually teaching an English as a second language class by Zoom for my church.
Oh my goodness. Wow.
So I'm making all the mistakes on Zoom. That's what I can tell you. Made them all.
That would be so challenging doing ESL remotely. I mean,
oh my gosh, you have no idea.
Have you done it before? Have you done other classes with students?
I taught it, yeah. So I've been teaching the class for a couple of years. So
this is great.
Does it work? Have I got it?
You got it. Just advance a couple slides. Let's make sure it's on.
Okay. Yeah. My daughter is co-teaching with me.
Oh, cool.
Just graduated from college. And so let's see if this is working. Oh, there it worked.
There we go.
It's a little bit slow. Okay. Excellent. Great. Okay, great. Yeah, she's the one who tells me when I do things wrong.
That's why we have Sanika and Cindy.
Exactly. We need some digital natives to make it all work.
But okay, this is great.
All right, excellent. So we're good.
Yeah. So I'll be back on.
I'm not. Okay, I'm not going to touch my screen. I'm going to work on a different device.
We are good. You just leave it right here and go get a drink of water.
Excellent.
See you in a little while.
Okay, great. Thanks.
Hi there, folks. It's Lisa Watkins. I have 1:27 Eastern Time. We're going to get started in just a couple minutes with our next speaker. Looking forward to continuing our conversation today. Hi, everyone. Welcome back. We're just before the half-hour mark, and we're going to get started. Just as a quick reminder, the rest of the afternoon will be, or morning for some of you, I apologize. We're going to be listening to another presentation, this one from Sarah Scholey of the NCQA. And then following that, we're going to split up into 3 breakout groups so that we can have a more intimate conversation experience just for about 25 minutes, and then we'll wrap up after that. So thanks for your patience, and really appreciate once again, you participating in this event. So with that, Dr. Scholey, are you prepared? You ready?
I am. Are you seeing the right screen?
I'm seeing the right screen, and I'm just going to introduce you now to our
Excellent.
Great. Okay, well, it is with great pleasure that I would introduce Dr. Sarah Scholey, who is the Vice President of Research and Analysis at the National Committee for Quality Assurance, our friend NCQA. She is an expert in health services and quality measurement in multiple settings through NCQA's HEDIS program, which all of you are very familiar with. She's also been deeply involved in assessment of aspects of the patient-centered medical home and has contributed to the development and implementation of important surveys. Specifically of interest to us is the patient-centered medical home, or PCMH version of the CAP survey. And what she's going to be doing is giving us a presentation titled Evaluating Patient Experience in 2020, something that is near and dear to all of our hearts, and also can be somewhat challenging. So we're really excited to have her expertise shared with us today, and we'll have a question and answer session following her presentation. Okay, with that, you're all set.
Okay, great. Thanks so much. This is a great opportunity for me to pull together some of my thoughts about care experiences and some of the challenges, some of the successes we've had and some of the challenges we face, and would love to have a discussion with you. I'm looking forward to the discussions to hear whether some of the things that I've been thinking about, whether they resonate with you, and whether you have some other ideas about where we could go as a field. So basically, I want to talk a little bit about the importance and challenges, some of the new opportunities, and set a course for the future. So I don't know about you, but in the role that I sit in, we hear a lot of questions and concerns about how we're getting input from individuals about their experiences of care. And I've just listed a few. The results aren't actionable, the response rates of long surveys, et cetera, et cetera. These actually became even more apparent this year with the pandemic because with the shutdown, some of our typical ways of collecting data were disrupted. The call centers usually involve people going to a call center and actually making phone calls. The mail was disrupted. And also we, at least for health plan, the health plan caps, we were collecting data in March, April, May about experiences in the previous year that were clearly, likely to be influenced by what people were experiencing at the point in time, right? So real question about that dynamic and how to do that. So throughout this presentation, I'm going to be going back and forth between health plan provider levels because we think about both of those and try to understand it. But most of the experience we have with CAPS, right, is at the health plan level. So really the question is, how do we get where we are with care experiences surveys, and what do we need for the future? So back in 2001, it was really a watershed moment when the Institute of Medicine, now the National Academy of Medicine, included patient-centeredness as a core component of quality. I mean, it really made us think that what individual patients think about, what their preferences, needs, values, everything that's important to an individual is a component of quality, and that we need to be assessing that. And that meant that care experiences surveys became a core component of quality ratings. And this is true today. And in fact, all the CMS value-based payment programs include a care experience survey. NCQA includes care experiences in our ratings of health plans. And even more, with the focus on patients over paperwork, CMS is increasing the weight of care experiences. In fact, more than doubling the weight of care experiences measures. So it's going from about, I think, 26% of a health plan score to 40%, nearly 40% of a star rating for Medicare Advantage plans. So more and more important, despite some of the concerns. So CAPS really, in this tide of saying patient-centeredness is important, we need surveys, the CAPS team that was formed by AHRQ, funded by AHRQ, brought legitimacy to care experiences surveys. They laid out principles for survey design, and they showed a rigorous development process. So the principles for design were that care experiences surveys need to focus on items where the patient is the best source of information or the only source. And importantly, to ask patients to report only on care that they have experienced or can observe. So that was a really big difference. And if you've worked with the CAPS team, you know that these principles are hugely important in the development of items. And it's really kind of been a reaction to the idea of asking people about their satisfaction with care. And also asking about items that are may not be as relevant to the care process, right? So the CAPS items, all of them use explicit references to the time frame, to the event, to the clinician or organization or whatever kind of entity is the focus of the survey. And that means that in a CAP survey, there are questions, there are entry questions that ask, did this happen to you? And then how often did something else happen? So when you ask about after hours care, the first question is, did you try to get after hours care? So it's really trying to it's building on the research that showed that people will answer any question you put in front of them, and that it's important to try to make sure that people are answering questions and that are relevant to them, where they have had an experience and where we can make fair comparisons across organizations. So the CAPS team brought that legitimacy, that kind of critical thinking about what are we trying to do here. And then they have a rigorous development process that includes literature reviews, focus groups, cognitive testing to make sure that items work, field testing. So we really have to give credit to the CAPS team for creating the science of how we do care experiences surveys. And in fact, we worked really hard when we were, I worked on research that informed the development of NCQA's Patient-Centered Medical Home Program. And we did research to try to understand how are we going to incorporate patient-centeredness into our evaluation of primary care practices seeking recognition. So we worked with the CAPS team to develop a survey specifically for medical homes. And the survey we developed included the core survey around access communication, and as well as supplemental items. This was based on, actually we did some public comment to get suggestions about content areas. We worked with an advisory panel. We did all those steps of focus groups and cognitive interviewing, and this PCMH supplement included items on the topics that you see here. And when we started this work, I was just actually had a chance to go back and read some of my some of the papers that we wrote, some of the progress notes we wrote, and even at that time, there was a lot of questions and concerns about the process, and some of the same kinds of concerns about needing rapid input. And the length of the survey, et cetera. Now, one of the questions that people always raise is that CAP surveys really don't guide quality improvement well. We know that some organizations have really figured out how to use CAPs for quality improvement. And when they do, they use it to identify areas for improvement. They monitor trends. They do provider level performance reporting and coaching. And we know that is something that's happening. Even when we hear people say it's not for quality improvement. I think the reason is that the model for capturing data for accountability surveys, which is CAPS is fundamentally about accountability, is different from what one might want for rapid cycle quality improvement. And I think that's where that disconnect happens. But the long and the short of it was, we developed the survey. We offered a distinction in patient experiences for organizations just to report the data. But the uptake was low. And what we heard, all of the barriers listed here, survey length, resources for implementation, lack of financial incentives, concerns about quality improvement. We want a net promoter score. I mean, we heard all of those concerns, and in the end, we had such low uptake, we were never able to create even benchmarks that we felt we could responsibly share. And we ended up retiring this distinction. So where do we go from here, or what's happening? Well, and actually, you kind of have to think about it. I mean, the work on the CAPs started in 1995. And this is the 25th anniversary of the CAPs, okay? So a lot has changed in how we think about consumer ratings, right? This is from a search I did because I'm going to the Williamsburg area this weekend, and I was looking for a place to stay, and all of us, we use data on ratings. Like, I won't go to a hotel less than a 4-star rating. We look at the comments because we want to know what did people not like, right? So how we approach consumer ratings has changed a lot since 1995. It's kind of embedded in how we do things. And if we think about the technology that's used for CAHPS surveys, that's also completely changed. Most CAHPS surveys are completed by mail or telephone. And these are data from the NHIS National Health Interview Survey that show 40% of adults live in a household with a working landline telephone. I just got rid of mine. My colleagues thought it was crazy that I still had a landline phone. So that means that actually the data that we have, how we're collecting data may not work very well. And also our experience, like, the Google and TripAdvisor and Yelp, those were all starting just as CAHPS was beginning and developing its approach, right? So what I'm hearing from people in the place where I sit is, I can't believe we're still doing mail and telephone surveys, right? Or using surveys developed when mail and telephone was the way to do it, because as we think about moving to other technologies that people are more used to using, the same type of surveys may not work. And as a result, we're seeing really low response rates. And you can see the red line and the ones below it all tracking together. Those are from our the survey, the health plan CAHPS surveys that are reported to NCQA. And here we see, response rates that were in the 30s 10 years ago are now down way below. And while we had a drop off this year due to COVID, it's on the trend line. And if you look for the, and actually this is 2019, it doesn't include 2020 data, I'm sorry, but the 2020 goes down, but it's on the trend line. It's not that much precipitous from here. And then, but Medicare is experiencing the same sort of decline. And, in a few more years when I and my peers are eligible for Medicare, I think we're going to see those lines continue to go down. So what instead, okay, so if we think about what's happening with CAHPS, what's going on? What are the other things that we're hearing? So, when we were looking at a CAHPS for patient-centered medical homes, we heard from our committee, I can still remember, being said, net promoter score, that's what people want to see. And in fact, what we see for the CAHPS survey for health plans, the plans can choose to add supplemental items as long as they aren't going to cause a problem. We review all of them, but we find that about half of commercial health plans include a net promoter score, which is getting at, how likely is it that you would recommend us? And which, I've heard multiple times from providers and organizations saying, this is what we're looking at as a relationship with a customer. And then on the other side, we're seeing more attention to relationship and support in newer tools that are being developed. And Rebecca Etz at Virginia Commonwealth developed this person-centered primary care measure. She did this through, multiple rounds of similar process to what the CAPS team uses, same kind of process, but without kind of restricting it to all of the CAPS rules. So this is 11 items. It has a single response set. The CAPS items, the response sets change depending on the kind of question. It includes items that are not about an experience. So the doctor or practice knows me as a person. That's an example of a question that wouldn't make it through the CAPS rules about an experience or behavior, because it's an appreciation of more of a relationship. And there was we tried to make that into a CAPS item, and it actually becomes a communication question about something about, I don't remember exactly how it's framed, but it's more about communicate the doctor. I should have looked it up before this, but when you turn it to that, I think what we're hearing is much more interest in this idea of the relationship. My doctor and I have been through a lot together. My doctor stands up for me. So the team that was working on this measure started from Barbara Starfield's framework for what primary care is, worked with experts and patients and others to get to these items. And they're using it now, but in a completely different way than CAPS, where actually they've got it crowdsourced. They've been reporting this year on crowdsourced results from this survey and others related to COVID, and they make it available for clinicians to offer it as something that you can use. It reminds me, if any of you have been around, John Wasson was doing this with the measure that he had. Did you get exactly what you wanted, exactly when you wanted from your care, right? So really much more appreciation than experience. So the other thing that we're hearing, right, just kind of getting back to, we look at the ratings, but really what we want to know is what happened, what were the, what were the comments, because they provide really valuable insight into what an experience is about and what went wrong. So CAPS actually has responded to this with a narrative elicitation protocol. And their protocol, has 5 questions. And these, they offer this as something that could be added to any CAPS survey as a way to get at those comments. So instead of saying, just briefly what worked and what didn't, what would you like to see improved? It actually goes into a very kind of structured approach to asking for comments that gets at that they've developed with the perspective of what we want is complete, balanced, meaningful, representative information. But what that does is it takes it from a single comments line to 5 pretty wordy questions for individuals to respond to. So I just want to talk a little bit about telehealth, because that is the thing that we're all experiencing right now, including virtual meetings and virtual visits are happening, and as a result of the pandemic and our social distancing rules. And this has really created a tremendous, I think, opportunities and concerns about care experiences. So we have actually very little research to guide us in this area about what works, and it's actually from anything that's kind of from a time period before COVID makes you wonder how relevant is it today. I was just talking with Karen Donnellan, who published a paper last year about virtual video visits, and what she showed is that in the work they did at Mass General, that for established patients, virtual video visits were preferred by patients. And both patients and clinicians had said overall quality was similar to in-person visits. So does that mean that virtual visits are good for everybody for every reason and work for everyone? Well, no, not really. I mean, that's part of what we need to struggle with today, because even though, some folks at Penn Medicine had a New England Journal Catalyst paper about, what are the issues today? We need to think about communication. Given that people are having these visits, is the communication really working well? What's the follow-up for access to care when you need it? How are we coordinating care? How responsive is the system to when you're not coming in person? And what's the impact on the team within the healthcare system of this? I think the bigger issue is really about access to technology. We did research with a community health center that was, really, they were a patient-centered medical home. They had all the systems in place that allowed them to go to virtual care. They had teams, they had protocols, they had Zoom available, but none of their patients were able to actually use Zoom for virtual visits. They've used it a little bit in behavioral health. And the challenge was people don't have the bandwidth. They might not have access to high-speed internet. If they have smartphones, they don't have data plans that allow them to use it for this kind of service. So there's really a concern. And we talked in Louisiana where people were where they were bringing mobile internet availability for making virtual visits possible. So this is really a key challenge for telehealth and a key opportunity. NCQA convened a task force on telehealth policy, and they recommended that we look at ways to leverage telehealth's digital aspects to improve timeliness, targeting, and engagement in assessing care experiences. And it's critical that we think about doing that for telehealth, but it might be that by learning through telehealth, we're going to learn about where to go in the future. So I believe that as we think about the plan for the future, we need to be thinking about what our goals are, what our methods are, and what the content should be, and kind of separate that out. Because I actually think in the care experiences world, we've focused on accountability. CAPS is for accountability. And the methods of mail and telephone surveys, which get at a small portion of patients, may give us a signal for accountability, but it's likely not giving us what we need for rapid cycle improvement. It also may not be giving us what we really need for targeted information on vulnerable groups, especially the groups that aren't going to be filling in those surveys. Maybe, is there a way for accountability to be a byproduct of a rapid cycle improvement survey? Is there a way to hold organizations accountable, like, in those ratings, instead of saying what's your CAPS survey, in this tight box of performance, what are you doing to really move the dime for specific population? The goals, I think we need to rethink. The methods. I cannot tell you how often I've been told we need something timely, we need something short, actionable, ready for mobile devices, simple wording, same response set, but also targeted to the specific populations. And so that might be that instead of surveying a general population sample, we target people who've had a hospital admission, about their outpatient care, that we target based on race and ethnicity, target based on complex needs, and combine that with qualitative methods like interviews and focus groups, and take advantage of these community advisory groups and to help interpret and target that work. And the last thing is about content. I have to tell you, the CAPS team is really right. I mean, they know how to develop items, and they're the items that we have for communication other pieces that are in the CAPS team, they've done this well. I think there's other items that people care about today that address relationship, that look at culture and trust. And there are some items that the CAPS team has used that are not part of the core sets that might be there. Telehealth. And I guess partly what we need is some capacity to add new topics. So how do you reconcile this long list of content with the methods? Well, not everybody gets all the questions. And we have to think about how we do it in a way that we target questions to people based on what's relevant to them, and that we use, you know, dynamic kind of a survey sampling that allows it. And there are many technology features that that would allow us to do this. Probably something we can learn from all of our all those organizations that use online surveys. So the key takeaways: care experience is our key component of quality. We need to be doing a better job of this. We want organizations to be accountable, and we want them to be accountable not just for where they are, but for improving. So today's approaches should provide us insight on experiences of diverse, vulnerable groups, timely actionable data, information on new care delivery, and simple tools. So that's really the charge I think we have for as we move from 2020 forward in care experiences. And I'd be delighted to hear your thoughts on what I've said and any suggestions. Thank you.
Sarah, thank you so much for that thoughtful and thorough presentation. So there are, I'm sure there are some questions out there, and first one actually is a specific one that came in from Dr. Richard Shunk with the Health Collaborative in Ohio. So specifically, he has asked if anyone has delved into the comparison of independent versus employed providers with regard to relationship scoring, with relationship in quotes. So does being the owner of a practice or an organization make accountability more likely? Is there some sense of that you've observed? Or I think this question actually is to everyone in the audience today.
I actually don't know the answer. I'm not aware of anything, but I think that's a good question. I think it does. Actually, the person who was most vociferous for me about this was not was employed, right? It's from a community health center saying we need a net promoter score. So I don't know that that would be obviously true, but maybe others have thoughts.
Yeah, or Dick, if you obviously have worked with a huge number of practices in your work. Is it something you've observed or think is a pattern?
It's more from personal experience, I guess, and from what I've seen, we work with a lot of independent groups, actually, fairly large groups that have multiple practices, but in some way, they've been able to communicate ownership of their satisfaction score. So it seems to me if we want individual patients or individual consumers of healthcare, if we want to focus on the individual there, so that we can understand where they're coming from. It seems like there's a counterpart to that, in that you could talk about, is there something in the system that we've created, in the groups that we've created, that somehow gets in the way of a provider feeling or having the resources needed to create that relationship that they need to have in order to be able to do that. I'm not saying that employed physicians don't have that. I'm just saying that it's something that I think we need to always be on the lookout for things that get in the way of doing that. So I think that, again, I've seen it on an individual level, and practices that I've talked to, turns out this particular independent physician practice group has very high scores, and I don't know if it's because they're independent. I just think it's worth looking at.
Good question.
Great, thank you. Deb Hurwitz just noted that anecdotally, this is in Rhode Island, their small owner-run practices always scored very high on the CAP survey. So that's just an observation they had over the years. Sure. I have a question from Eric Muther, who's our convener in the Philadelphia region.
Hi, thanks, Lisa, and great presentation, Dr. Sholay. I really enjoyed that. You're probably familiar with work that was done in 2015 by the Massachusetts Health Quality Partners, and I believe it was the one of the California organizations that looked at the impact of perhaps shortening the CAP survey. So they explored a short form version, but also did some research on what would be the impact of emailing the survey as opposed to, as you mentioned, primarily using phone or mail. Now, this is 5 years old, but the results of that were essentially that that neither shortening it nor emailing it made any significant difference. There were some differences with certain demographic groups, if I recall. But, you know, the takeaway was that, okay, so getting a better response rate on CAPS is not just simply making it shorter or not just, you know, moving into the 21st century and emailing it to people. So when I saw that, those cascading lines that you showed of the response rate, I feel like we as those working in our healthcare system to improve and both improve quality, but also to make significant systemic improvements, I think we need to think out of the box about how we capture care experience information from patients, and whether that is new methods, you know, beyond obviously email and even electronic surveys, whether it's through apps or through some other method. But we also need to, I think, begin engaging with clinicians about having conversations with patients around the importance of capturing that information. I personally, I have an annual visit every year. Thankfully, I've been pretty healthy, so I don't go that often to the doctor. I've never heard my doctor ask anything about the survey, even though I have received, I happened to go to a CPC Plus practice and received a survey from them. But I've never heard anyone in a doctor office mention, you know, like I do at my car dealership, that, you know, what can we do to make sure we get 5-star service from you? I've never heard any provider talking to me about that. So that might be one thing. And the other approach might even be for health plans or other stakeholders to consider some incentive, that if you return your survey, you get $5 knocked off your next copay or something along those lines. But I'm just curious if there's been any discussion about what we can do around those cascading response rates.
Great suggestions. Thanks, Eric. So, right, I think the issue is the emails. Actually, I mean, we just have to jump over email and go to text or apps or something, because that all of the efforts to try to use email have to do with the accuracy of the email addresses, and then whether people will use an email, and whether you can actually do something more that's more like a 3 or 4 item text-based survey that you could actually do through text, or and it's brief enough. So I do think there are, you know, we have to think about different ways to use technology. And one of my colleagues was saying chatbots or other, you know, other things. So there is that technology that we have to jump over. In terms of engaging, so actually, I mean, there's been a lot of focus, and I'd love to hear your thoughts about this. So in, you know, a lot of the work I do is about getting information directly from individuals. Before the visit, it's about patient-reported outcomes like the PHQ or other tools that help us understand, you know, behavior and symptoms and social needs, right? So we have a whole infrastructure that people are developing for that. And all of that information is tightly tied into the care data systems, because the purpose of it is to guide your care. But for care experiences, one of our fundamental rules has been anonymous. It has to be anonymous. It can't be tracked back to the individual. And the kind of conversation you have, you know, I usually pull that out as, I mean, really and truly, I went to the car and they gave me the survey filled out and said, here's how to fill it out, right? And so there's been a lot, we've actually done studies that saying, you know, you don't want to ask the questions on site, because if you do, somebody could do what the car dealership says, which is only a 5-star gets me, right?
Yeah, I wouldn't hold them up as a best practice by any means for that very reason. And certainly, I think the sort of anonymous aspect does need to be maintained. So maybe it's just emphasizing the importance of them completing that, and that it is a anonymous way for you to provide feedback on the care that my office is providing to you, or something along those lines.
Right. And so how do you do that in a way that is actually, you know, where you can open up that opportunity to say this, well, this is what would really help, or these are the kinds of stories. That's where the qualitative research and having a community, you know, a council can help you to really help to guide that discussion. I like the incentives. You know what, we've tried to offer that. I think there are like rules about it, but I'll go back. But I think those are some really important ideas. I'd love to hear what others think about, you know, that having that conversation with a patient, like, how are we doing? You know, is there something that would help?
Shall I call on someone? Our colleagues from Blue Cross Blue Shield of Arkansas are well represented here. I don't know, Alicia, Missy, or Adam, if you wanted to share anything about that. I know you've been grappling with this for a long time. No? Anyone?
This is Adam. I'll speak up here. So from a CAPS patient experience perspective, the CAPS survey is quite long. And so we've utilized a vendor that has a CAPS Express survey, and it's a 16-question survey. It's snail mail and emailed to members that have had a visit within the last 6 months. So it's a one time in the year CAPS survey. And so we got a 15% response rate to that survey, which you know, we were pleased with the results. It beat the expectations of the vendor, so we were I guess excited about that. But so it's 16 questions. It gets to the point, and we got enough data from it to be able to assess patient experience. So we were pleased with it.
Thank you, Adam. We have our colleagues, I think at least maybe Anthony Murdoch, you're here from Blue KC, Kansas City. Are you using something similar to what Adam just described, or? He's not quite at his desk. So,
I'm sorry, can you hear me? I'm sorry, can you hear me now?
We can, thank you.
I was having audio issues, sorry.
That's all right.
This is actually something that we keep coming back to because a few years ago, we just started letting all of our participating groups have their own process in place, and us just use what they were gathering and got away from doing it ourselves. And I know it's something that we do bring up to which years should we start bringing it back and doing it ourselves to see as a whole, and having the commonality of knowing that it's been done the same for all of our members, but it's kind of in our pathway. But I do agree, having something that has been redesigned, maybe using technology versus the old process, would really help reestablish and re-engage patients in the process.
Thank you, Anthony. Anyone else have anything to share about that? I mean, I think there are many, everybody's sort of come to some sort of a, you know, equilibrated somehow so that you feel like you're getting some information from the CAPS opportunity, but how does that, you know, is it meeting your needs? And if you could snap your fingers and make it better, what would it be? Well, something to consider moving forward. Sarah, do you have further just comments to share with our group? We're just about at time, and just want to make sure that you've had a chance to share what you wanted to.
No, I happy to elaborate on any of the topics I've shared here, but this has been helpful. I guess actually the question I have is, I mean, the biggest question I have is, the complaint we get is, can't improve it, can't use it for quality improvement, right? Part of it is, you know, that it's just a really stable thing and there's not anything you can do that really changes the numbers. And the second part is, it's just not, we're not getting data in a way that it can really guide our quality improvement efforts. So in your organizations, with the practices you're working with, how are those concerns, and how are you overcoming them, if they are? Are you using care surveys for quality improvement, or is it primarily an accountability piece? So I see the note in the chat from Howard that is consistent with what we've heard. Yeah.
Yeah, so it sounds like the effort, the lift on the part of the practices is certainly makes it, I mean, it's potentially very helpful, but is it helpful in a timely manner? And all those questions still come up. Anybody else have a quick response to Dr. Scholey's question to you? These are really important and complicated topics, and we realize that we're not going to get instant answers on any of this, but this is just so valuable to have this opportunity to be part of the process. And so turning back to you, Sarah, I want to thank you so much for your wonderful presentation today of really long, complex information that all of us are vaguely familiar with, but the way you approached it was incredibly helpful. Thank you so much for sharing your expertise and experience with us. And people obviously will be able to reach you with continued comments if they have anything they
Absolutely.
need. Okay, great. And we will then thank you once again, and we're going to move on to the next phase of our meeting, which is our breakout sessions. These are an opportunity to have a free-form conversation. Not that we've had a terribly structured conversation today, I realize, but this is a chance for us to be in smaller groups of about 10, I think, in each of the three groups that we're going to be splitting up into. And I wanted to pose not necessarily a specific question, but a structure for you to use as you're having this opportunity to speak with your peers in a smaller setting. And so posing this idea of the barriers and potential take-home ideas that were identified today in our previous discussion with the Oregon and Community Catalyst speakers, as well as with Dr. Scholey from NCQA. What of these really are helpful to you as you think about creating effective patient engagement? And my friend Julie Shills, who's on the line today, pointed out that this really could be viewed through either the lens of primary care practices delivering care, or through the lens of payers engaging with their members, which could be broader than just primary care. I think our focus of this group is primary care, but I want to put out there that if the discussion goes elsewhere, I think that's really important and encourage you to do that. So just in terms of the process here, we have pre-assigned all of you to one of 3 rooms. Each room has a technical person who can help with support if there's a problem. And in addition, each room has a friendly guest who will be facilitating the discussion. And so we're really excited to have this opportunity, as I said, to just speak as if we were in person and in smaller groups. We're left about 25 minutes for this part of the day, and then there will be a little reminder that we're about to come back together as a full group in 25 minutes. So with that, have a good time. And Cindy, who's our host from Milbank, is going to put us into our rooms right now. Thank you.
Hi, Alicia. You'll have to join room number 1.
looks like people are filtering in.
Hi, everyone. We're back. It'll take just a moment for everybody to re-emerge. I hope you had productive opportunities to talk together. As I mentioned before, we're not looking for any major output products, anything of these discussions, but just seemed like a good opportunity to be able to debrief a little bit and to talk about some of the things that we may have learned from each other or from our speakers today. So with that, I guess I'd like to just maybe have a very brief, just sort of highlights of just the last half hour of conversation. Trying to make sure I have everybody here. I think, Howard, are you still with us? Did you manage to get replaced here?
I am still here.
Great. Hi. You want to just give like a 1 or 2 minute summary of our discussion while we were together?
Yeah, so it was very, it was a great discussion about largely about the surveys, and many people pointed out the fact that there's still some frustrations with surveys. There's some challenges in terms of getting them out to patients, having patients be able to respond. And this was both from the perspective of health plans and from the perspective of PCMH programs. The general consensus of they are long, they may not always be actionable, and a lot of discussion about how technology, modern technology, might be able to assist in being able to get those surveys out to patients in a shorter time frame, so that the information and the response is fresh and relevant rather than delayed and cold and maybe not as relevant. And also perhaps, although it didn't sound like anybody really proved it, but that perhaps technology might be able to increase the return rate. There was some people said yes, some people said no, some experiences were kind of mixed on that. But I think it was a general consensus, Lisa, that there's work to be done there, and that there are some, there is a need for being able to understand what our consumers feel about the care that they're getting from practices, and the plans need to get that information, and we haven't completely solved the best way to do it yet.
Thank you, Howard. Just one thing that did come up that I want to highlight, and Anne was actually going to mention it, but our colleague David Kendrick from My Health Access in Oklahoma has created an app. He and his team have created an app where they're able to screen patients on site at a visit for social determinants of health and risk of social issues, socioeconomic issues, and health security. So, and they also went through an incredible process around making sure that they were able to demonstrate that this was a secure set of communications. But I know that this is now a couple of years into it, and so that may be something for us to think about to get David maybe to sort of give us an update on that, or his colleague Jennifer, who's been working on this with him for a few years. So it may be an opportunity to use that technology in such a way that it's applicable to understanding patient experience with the practice. Julie Shills, I know you were involved in a different group today. I don't know if you wanted to share what you had learned.
Yeah, and we started with surveys as well, and I think I think one of the difficulties in discussing CAPS is that there's a lot of stakeholders who are accountable to CAPS. So sometimes I think it lends itself to a struggle in having a conversation about how can we really move forward in perhaps enhancements to CAPS surveys, when for both payers and providers in different ways, there's a high amount of accountability to that survey. And so how do you start that dialogue on something that, you know, it's a part of how you're being judged as well in the work that you're doing. That surfaced a conversation around surveys are also the aggregate of, you know, impressions, and what we're talking about in engagement is that personal relationship, especially when you're talking about primary care. So where are the opportunities to think about the different methods that can really drive understanding the personal relationship and engagement, that you know, overall surveys of a population don't necessarily give you. And that kind of triggered us to start thinking about patient advisory councils, and how is that an opportunity within those structures and organizations to garner that input and information in a way that it really does become something that's part of a virtuous cycle of quality improvement. We did talk about a few other things, but team, anything else from that sort of the conversation we had around surveys that you would want to make sure is highlighted? Okay, I'm going to keep going. Okay, thanks. And then we moved into telehealth and talking about a little bit of a different part of the same conversation about patient engagement. You know, the idea that with COVID-19, telehealth is here to stay, but when is it right? What is a good use of telehealth, and how do we make sure we don't go overboard necessarily, but find that right mix of how telehealth can be utilized effectively, and continue to assure that it's supporting primary care in the essence of being advanced primary care. And lastly, we talked a little bit about the investment in you know, how are we assuring investments in primary care that align with tracking or knowing engagement. We talk a lot about moving away from fee-for-service, which is the right conversation to have. And we talk about prospective payments, and some of us have lived in spaces both on provider and payer side of being in capitation. But there's, in that Venn diagram, there's this space that is a lot of, oh, you can do a lot of things, but whether the input in the payment is there to assure that those lot of things can happen tends to be a disconnect. So how do we, because this is so important for patients in primary care and their staff to be engaged, how do we think about within the investment structure assuring that importance is tapped into with payment methodologies. And it brought up a question, is someone doing that well? Has someone sort of put into their value-based payment model structures a focus through payment to assure that practices are understanding if they are engaging their patients effectively, and if not, making those quality improvement changes. So that was a bit of an open question to the group, if they're aware of anything.
Julie, thank you. That's sounds like you packed a huge amount into 30 minutes. That's great. And then Alicia, I believe you were involved in our third group. If you wanted to just give a quick update on what you heard.
Absolutely. I'm very impressed that Julie covered so much because our time went very quickly in our group. And I think we got most of our discussions were around the NCQA survey and some of those things that we spoke, and then we agreed we're going to continue the discussion going forward as well, because it was a good discussion about the surveys, understanding that they needed to take place. But I think that the summary I thought was very helpful to me, and I had not thought about this in the past, is in some ways the NCQA survey has become a regulatory tool versus a quality improvement tool. And Sarah did a nice job kind of summarizing that and bringing that to my attention. Because if you think about it, we get so frustrated, but in reality, it is probably regulation more than anything. And so that has led many practices and payers to figure out ways that we come up with quality improvement tools, be it a survey done by the practice, or is there a simpler way to do it for the payer or others to recognize the improvements and the changes in a practice. It has to be much more timely. And then also some of the concerns around the delay and the people that truly would be committed to the survey sometimes are the people that have bad experiences. So is that a good tool to reward or not reward providers based upon that? The other key thing that I thought was interesting in our discussion was the generational, different generations, and should we segment the responses based upon a population and what generation they are going to respond in different manners. And the old days of everyone answering their mail and sitting down to fill out that survey, we're just not there anymore. And so focusing on some different populations and generations, and some of the other needs that I think we could have or use from that. And I know, Lisa, you've heard me tell this story before that, we go to take our animals to our vet and we can get those questions and get responses and actions pretty quickly. But this is a paper document that has 60 or plus questions, and then we want to make, movement or action upon that. So good discussion. I don't know if anyone else from the group would like to add anything else. Those are just some of the keynotes I had for my group.
Thanks, Alicia. Well, this has been a great 3 hours, and I really appreciate all of you staying on for this length of time and participating and sharing your time, sharing your energy, and sharing your knowledge with each other. So I'm very proud to still have our virtual network, and looking, as I said, looking forward to someday sitting together and sharing a meal together and having the opportunity to continue our connections with each other in person, which I really do believe will happen. And not this year, but hopefully soon. So thanks everyone for being part of this. The slides from this morning are available, and we'll be sharing those, and as well as some notes from the meeting, and I'll follow up. Email will go out in the next week or two, just to follow up on this and make sure that all our questions are there and can be pondered and hopefully answered. And I think we'll be having another one of these seminars in the beginning of 2021, probably in January. So thanks to everyone for being here. Thanks for being my colleagues, and everyone stay well.
Thank you, Lisa.
Thank you, Lisa.
Thanks.
Thanks, Lisa.